Afternoon. How's everybody doing? Okay, there we go. Thank you so much for coming. My name is Jermaine Hampton, Vice President of Workforce Development and Strategic Initiatives with the Los Angeles County Economic Development Corporation. And today, thank you for coming and welcome to the LAEDC Future Forum, the future of advancing healthcare with AI, powered by our great partners at California State Dominguez Hills and also California State University, LA. Please give them a round of applause. So today we have an excellent program that's going to shape up for you all. Artificial intelligence is rapidly transforming the way healthcare is delivered, how professionals train, and how communities receive care. Los Angeles, home to one of the largest and most diverse healthcare ecosystems in the world, must lead with both innovation and inclusion. This Future Forum unites healthcare providers, academic leaders, AI experts, and workforce development partners to explore possibilities and address critical questions. Who benefits from AI in healthcare? What skills will define the future workforce? How do we ensure equity and trust as technology evolves? Together, we build a future where innovation saves lives and expands access. So a few key themes today that we'll get into is AI in practice, education and workforce readiness. We'll also talk about equity and access, ethics and trust, cross-sector collaboration, and more. And so without further ado, I'd like to welcome the CFO and Executive Vice President for the LAEDC, Kendall Turner.
Well, good afternoon, everyone, and welcome to LAEDC's Future Forum, the use of AI in advanced healthcare. I'm Kendall Turner, Executive Vice President and Chief Financial Officer of LA County Economic Development Corporation. It's so good to see the room full with brilliant minds, community partners, and innovators who care deeply about the future of healthcare in Los Angeles County. First, a big thank you to our co-hosts, Cal State Dominguez Hills, and our partners, Cal State LA. Yes, thank you. For your incredible leadership and your deep commitment to workforce development, equity, and innovation. We're gathered here at a pivotal moment, one where artificial intelligence is transforming healthcare right before our eyes. While it is exciting, it is complex. From diagnostics to hospital operations, AI is changing what's possible. But with every breakthrough, we have a responsibility to pause and ask, who benefits, who's being left out, and how do we make sure equity is built in and not bolted on? Because, let's be honest, technology has often outpaced inclusion. Historically, disinvested communities, Black, Latino, Indigenous, immigrant, and low-income residents have often borne the brunt of inequities in both healthcare access and economic opportunity. So yes, AI can revolutionize care, but it can also widen the gap unless we act intentionally. And that's exactly what we're going to do. Because equity cannot be an afterthought in the age of AI, it has to be the starting point. It's how we train our healthcare workforce, it's how we design new systems, it's how we make sure innovation truly serves everyone, especially those who've been left out far too long. Today's forum brings together an incredible group of leaders, clinicians, technologists, educators, and advocates, all focused on key questions. How do we prepare our workforce for AI-enhanced roles? How do colleges and training systems stay ahead of what is to come? How can AI serve communities instead of excluding them? And how do we uphold trust, transparency, and responsibility as technology evolves? So thank you, truly, for being here, for showing up with curiosity, with purpose, and with heart. Together, we're not just talking about the future of healthcare, we're shaping it. So let's get started.
Thank you, Kendall. Appreciate you. And Kendall will be back up for some closing remarks at the end of this. And so, without further ado, I want to bring up our next speaker, one of my favorite presidents in Los Angeles County, Dr. Thomas A. Parham, President of California State University, Dominguez Hills. And I do, wait, real quick. I would not be doing my just due if I didn't read this gentleman's bio. It's bifurcated just a little bit because yeah. I'm gonna read just a little, just to give him a little taste. So Thomas A. Parham, PhD, is the 11th president of California State University, Dominguez Hills, a highly diverse public university serving communities across South Central and the South Bay of Los Angeles County. A licensed psychologist and nationally respected scholar, Dr. P, as many say, has more than 40 years of experience advancing equity, identity development, and mental health, particularly within African American communities. Prior to joining CSUDH, Dr. Parham spent over 3 decades at UC Irvine in senior leadership roles, including Vice Chancellor for Student Affairs. He has authored numerous influential books and publications on African psychology, multicultural counseling, and is a past president of both the National Association of Black Psychologists and Association for Multicultural Counseling and Development. A champion for youth empowerment and community uplift, Dr. Parham helped establish impactful mentorship and rites of passage initiatives in Orange and Los Angeles counties. His leadership and advocacy have earned him widespread recognition, including honors from the American Psychological Association, the California Legislative Black Caucus, GLAC, and prominent civic organizations. A Southern California native, Dr. Parham holds a degree from UC Irvine, Washington University in St. Louis, and Southern Illinois University. He resides in Southern California with his wife, Davida. Please welcome to the stage President Parham.
Let me say good afternoon. Say good afternoon to the rest of you. Good afternoon. Thank you, Jermaine and Kendall, both for that too long introduction. And welcome to the Toro Nation. Please give my best to your president, Stephen Chung, always a good friend, and say hello to him for me, if you would. As I welcome you to the California State University, Dominguez Hills, we're delighted to partner with LAEDC and our sister campus at Cal State University, Los Angeles, in bringing together forums like this. I've argued in the past that these institutions should be the places where the most important issues of our day become the topics of critical discourse and analysis. Where better should they be than right here at Cal State University, Dominguez Hills, and some of the other sites. So we're proud to partner in providing these future forums. When I think about creativity and innovation, I'm clear that they yield significant results. And they do so across many domains and many disciplines. And yet understanding a piece of African wisdom that I've stylized over time in some of my writings, I've argued that life at its best is a creative synthesis of opposites in fruitful harmony. Let me say that again. Life at its best is always a creative synthesis of opposites in fruitful harmony. Has a lot of different meanings. One of them is sometimes your greatest strength can be your greatest weakness. Sometimes your greatest weakness can be what? Your greatest strength. And so even the prophetic voice of one of my heroes, Dr. Martin Luther King, reminded us some 63 years ago, way back in 1962, that we should be careful that we don't allow the means by which we live to outpace the ends for which we live. Y'all with me? Got to be careful that the means by which we live never outpace the ends for which we live. So even in the midst of technological innovation, it allows us to do some spectacular things that we could only dream about years ago. But there's always a cost, there's always a price that we have to pay, and we have to make sure that we aren't sacrificing, right, what is core in terms of our values and principles for convenience. So it is with this future of AI, particularly in the healthcare arena, that it's important to recognize that with each new discovery can enhance as well as hinder progress and outcomes. We talked about one of those in Kendall's analysis, that oftentimes with new innovations, there's certain segments that have and certain segments that have not. There's some folk who get left behind in the same way that the technological revolution happened and the digital divide got wider. Y'all remember COVID? Everybody said, well, we got the technology. When COVID comes, we'll just pivot and work from home. Do you know that on a campus like this, where 91% students of color on this campus, I have the second largest percentage of Latino students of any public university in this whole state of California. I have the largest percentage of black students of any public university in this entire state. But among that 91% students of color, 66% are first generation, 73% of my kids are Pell eligible. 60% of that cohort have an EFC, expected family contribution of 0. They are very economically challenged. Everybody said, let's just pivot and go online. 50% of my folk didn't even have devices to do so. You thought about that? If they had a device, there was one at home that mom and dad had to use to work, they had to use to go to college, their siblings had to use to go to school. If they even had internet access in the home at all, because they're used to running down to the Starbucks down the corner. Remember that? That was now closed, that they couldn't get access to. The digital divide was real, but we got exposed in that space. Crisis does 3 things. Reveals character, exposes weakness, but it also creates opportunity. AI is not a crisis. AI is about that innovation and creativity and discovery I talked about earlier. But if life is a synthesis of opposites and fruitful harmony, guess what? We got to make sure that what is our best strength does not become our worst weakness. Again, the means by which we live can never outpace the ends for which we live. So when we seek to learn and discover new facts and data, when we need answers to complex problems or dilemmas that we struggle to unravel, when we take creativity and innovation that represents the best of our human ingenuity and try to amplify it, it can lead to keener insights, broadened perspectives, opportunities to consider a broader range of contextual factors, and accelerated problem solving, particularly in the healthcare arena. That's absolutely true. That's what we're about to learn about today. Artificial intelligence is important for the future of higher education as well as healthcare, because it can enable personalized learning, streamline administrative tasks for our faculty and staff. It can enhance the overall student experience through tools like intelligent tutoring and accessibility support. Its integration can improve educational outcomes by adapting to individual student needs. But the duality of AI suggests that it also presents us with ethical challenges regarding the way in which we use and quantify and store data, even if we're allowed to even share it. Look at all the AI we use that gathers all the biometrics we use even to go into basketball arenas and other places. What happens with all that data? What are they doing with the biometrics that they gather? And who even knows and knows enough to even ask the question about what are we doing? And if we always have a half full glass, which I invite you to have, we think, there's new innovation that improves access, it improves security, it does a whole bunch of things. But for those of us who may have more scandalous intent, it creates an opportunity for them to exploit as well. We got to be careful about that, even in the healthcare arena. So security, academic integrity, and responsibility. All of those are issues that have to be addressed as well. So I close by reminding us that implementing AI and the AI-based tools thoughtfully and strategically is important, because it's my belief that institutions can meet the evolving workforce and community needs if we do so intelligently and with purpose. Lastly, I'll say it is true that you've heard that I do plan on taking my leave at the end of this calendar year. So December 31st will be my last day as president on this campus as I step into retirement. Jermaine was right. I've been at this a long time, 44 years in higher ed. First as an Ivy League professor, then at the University of California, Irvine, and now my last 8 years here at Dominguez Hills. But I'm reminded, much like the ancestors who built the Great Pyramids, personalities come and go, but principles and truth, ladies and gentlemen, are like those chewy Tootsie Rolls. They last a long time, yes? So I need you chewing on this future forum idea a long time. But I need you approaching it with not a half empty, but a half full glass. And in higher ed, we need to learn that lesson ourselves. When AI first approached, right, our doors a couple of years ago, all of our faculty, our staff start worrying about, but what happens to academic integrity? What happens if someone writes a paper, right, and turns it in that they really didn't write? What happens if, right, it leads to academic dishonesty? We only found the half-empty glass elements of it, and it stunted our growth. And AI is just chugging ahead, and now higher ed is looking to catch up. I hope healthcare does not have to do the same. So I invite you to approach this with a half-full glass, with a mind on the Dr. King, who reminds us that the means by which we live should never outpace the ends for which we live. With that, I'll say, welcome to the People's House. This is your California State University, Dominguez Hills. Thank you.
Come on now, y'all got to give it up one more time for President P. That man said he's stepping away after 44 years. That's a big deal. That's a big deal. That's a lot of leadership to follow there, and thank you for those words as well. And so let's get to the conversation, right? So for this particular conversation, this is going to be our panel discussion. Just be mindful. Save your questions for the end of the conversation. We'll also have our networking hour that will happen directly following this event right over here to my left. And so really think about what's being said on the stage here and how you can take that back to the communities, the businesses, and the places you're from and really capitalize on this conversation. This shouldn't just end in a conversation. This should be a continuous activity, and it should be something that we continue to influence, and it should leave this room. It should not stop here. So without further ado, let me bring up our moderator, Dr. Benjamin Tang. Dr. Ben Tang is professor of Department of Computer Science here at California State University, Dominguez Hills. He received his PhD in 2007 in computer science from Stony Brook University and was a member of Wings Lab directed by Dr. Daz. He received his MS degree of computer science in 2002 and materials science from Stony Brook University and a BS in physics from Peking University in China. Please welcome Dr. Ben Tang.
Good afternoon. Again, my name is Ben Tang. I'm a faculty member of Computer Science Department here at Dominguez Hills. It is my pleasure to welcome all of you to this panel discussion. And it is my greatest honor to introduce you our distinguished panel of experts. So when I introduce each of them, and one by one, they will come to a podium. And then we're going to have a fantastic set of discussion, from their working experience, from their perspective, their expertise, and their vision for the future of AI and healthcare. All right, so we have around 1 hour to do. And please engage in a way that we can all learn from each other, especially to inspire each other, and to bring this revolution to the next chapter. So I'm glad to first of all introduce Dr. Thomas Kingsley. And Dr. Kingsley is an assistant professor of clinical medicine and inpatient physician informatist at UCLA Health. He's double board certified in internal medicine and clinical informatics and a practicing hospitalist. Previously, he led Mayo Clinic's AI and digital health transformation and directed an NSF-funded AI lab. He regularly published and speaks on AI in medicine and biomedical informatics and has held national leadership roles. So let's welcome Dr. Kingsley. Welcome. All right, so our next speaker is Dr. Seth Kurzban. Dr. Kurzban teaches graduate level social work, leads an forensic social work cluster at Cal State LA, and has more than a decade of experience developing interventions for justice-involved populations. His research spans vocational, cognitive rehabilitation, homelessness, and mental health, and he served on the faculty of the USC Center for AI and Society. Let's welcome Dr. Kurzban. So our next distinguished speaker is Ms. Margaret Tucker. With a background in biochemistry, molecular biology, and oncology research at the Cedars-Sinai and NIH, Margaret designs and deploys generative agentic AI solutions in enterprise healthcare settings. She focuses especially on responsible AI deployment, operational efficiency, patient safety, and equitable outcomes, bringing AI innovation and real-world clinical transformations. Let's welcome Ms. Tucker. So our next speaker is Dr. Nola Oganyemi. So she is the director of the Center for Biomedical Informatics and the professor of preventive and social medicine at the Charles R. Drew University of Medicine and Science. A computer scientist and a biomedical informatics researcher, she also serves as an adjunct professor in radiological sciences at the David Geffen School of Medicine at UCLA. Prior to joining CDU, she was a faculty member at Brigham and Women's Hospital and Harvard Medical School, and affiliated with the Harvard-MIT Division of Health Sciences and Technology. Dr. Oganyemi earned her BA in computer science from Bernard College, Columbia University, and her MSc and PhD in computer and information science from the University of Pennsylvania. Let's welcome Dr. Oganyemi. Last but not least, Dr. Roman Sandler. So he is the co-founder and chief technology officer at iCardio.ai. He leads AI research, data science, and regulatory strategy for the company's mission to automate cardiac ultrasound interpretation. With a PhD in biomedical engineering and over a decade of experience leading ML teams in biotech and defense, Dr. Sandler has screening and FDA has guided iCardio.ai to achieve both FDA breakthrough device designations for aortic stenosis. Sorry, I even have to look up the dictionary to find out what this is all about. So I'm looking forward to this new technology. This screening and FDA clearance for echo measure, which automates over a dozen echocardiographic measurements for the 30+ million echoes performed annually in the US. His work addresses critical healthcare challenges, including the severe shortage of cardiologists and sonographers while reducing diagnostic variability that leaves many cardiac pathologies untreated. Under his technical leadership, iCardio.ai was awarded the 2024 Roddenberry Prize Grand Prize for pioneering the use of AI to democratize access to expert-led cardiac diagnostics in underserved communities worldwide. Let's welcome Dr. Sandler. Please take a seat. So we do have quite a few interesting questions. And to start with, I would like each panelist to briefly introduce your role, your daily role and responsibilities in your organization. And after that, describe one way AI is currently being used or soon will be in your organization or domain to achieve healthcare. Okay, so probably I will start with Thomas.
Yeah, thank you. So I am the new director of applied artificial intelligence at UCLA. I started that role October 6th. I had transitioned from my role at Mayo Clinic and joined UCLA about a year prior. So in my role, it's pretty broad. So part of the role is developing the strategy, AI strategy for UCLA Health. Part of my role is trying to figure out the needs of our organization, and is there a role for AI in solving some of our challenges? So that looks like, evaluating vendors and companies. We also have an AI development lab where we build tools internally, so I work with our data science team on that as well. And then there's a big part of the role that is, how do we train our workforce in AI, and how do we do, even earlier on in medical education, the use of these AI tools that are going to become so ubiquitous. And so, I've been in the field of AI in healthcare for over a decade, and if I look back even 5 years ago, the amount of tools that we had in practice, were maybe a few. Now, we're like Epic, our electronic health record, they have maybe 100 tools coming down the pipeline in the next few months that we have to evaluate, and so there's just a deluge now of healthcare AI products. So for a field that has often been well behind the technology curve, we are now experiencing this rapid transformation. And so that's been a big part of my day-to-day work life and how healthcare is being transformed in front of my eyes, which is very different than it's been in the past. So.
Thank you, Thomas. We are further looking forward to the discussion. So our next one is Seth, please.
Hi, Seth Kurzban. Thank you for having me. My day-to-day role is primarily teaching in the School of Social Work. So I think from everyone's bio, I may be the least knowledgeable about the computer science side, but as a social worker, for the past few decades, I've been engaged in trying to design interventions that do use technology, so using informatics to drive mental health care, and using AI to try to help identify and train peer navigators. Currently, I've been working with a company to try to create an avatar that could help foster care youth so that they could reach out, because sometimes they can't speak with their foster parents, they can't sometimes speak with their real parents, so there's really no one they could turn to. So AI offers the possibility of help around the clock. So I look forward to hearing from today's discussion how the AI side, the more computer side, can incorporate some of the social problems and the populations that need AI in different ways than I think has been rolled out to date. So I look forward.
Thank you, Seth. Let's have Margaret, please.
Hi, everyone. Marguerite Tucker. I'm an AI product manager at CHLA. I previously come from the wet lab world, so as a cancer scientist, a researcher, and I did that for about 7 or 8 years, and I pivoted into product management, specifically AI product management. And I work for the Innovation Studio specifically at CHLA, so what we do is launch products through responsible AI, and our focus is clinical excellence. And so we're trying to solve pretty pervasive and immediate problems that the hospital is facing. So sometimes that looks like building a tool for nurses to be more efficient in their day-to-day work life, or sometimes that looks like helping physicians out with their scribing and reducing that pajama time, as we call it, or just making sure that physicians don't have to continuously work even when they go home and they're off the clock if they're not on call. So we use AI pretty much every single day. We launch about 8 to 10 new products, some AI-driven, some not, about every fiscal year. So primarily they're grant funded, so we rely on that heavily. But yeah, we're always doing something in AI, and it's about, for us, continuous discovery. So what that looks like is assessing needs constantly, asking questions, and not just building something for the sake of building it, but building it so it's actually long-standing and it'll hopefully stand the test of time. So that's a bit about me. Happy to be here.
Thank you, Margaret. Thank you. Lola, please.
So I'm Lola Ogunyemi again, a professor at Charles Drew University. I do a lot of teaching. I also do research. I teach master's students in biomedical sciences, and most of them are on the pathway to medical school. And basically teach them about biomedical informatics, about EHR systems, about AI. And one of the things we'll hopefully get into is their anxiety about AI displacing them in the workplace. But I also do research, NIH-funded research. I've worked with ophthalmologists and infectious diseases specialists to look at how AI can help in the safety net with predicting conditions and then prioritizing resources to sort of reach out to people who otherwise might get left behind. I'll talk hopefully a little bit more about that later. So yeah, my daily life looks like research and teaching, but my interest is in AI and how it can help in the safety net and spaces that are non-academic medical centers where a lot of disadvantages could be reduced by using AI, in my view.
Thank you, Lola. So, Roman, go ahead.
Thank you again so much for having me. So at iCardio, we do AI interpretation for echocardiography. Each one of us in this room has a heart. As we get older, almost every single one of us will start having some sort of heart problems, and echo is the forefront modality for screening for heart disease. It's relatively inexpensive and safe. There's 30 million done each year in the US, about 100 million globally. And right now it takes about an hour of time between the sonographer who conducts the exam and the interpreting cardiologist to interpret and complete one of these exams. And what our mission as a company is to cut down that time. A lot of the time is spent by the sonographer just button clicking, measuring things by hand. And we think that time could be much better used elsewhere. So that's kind of our main company product and direction. But as far as how I use AI every day, I mean, I guess at this point, probably like many of us in this room, I can't imagine my day without it. I use it for everything, for drafting emails, to writing code, to database queries. I had occasion to look back at one of the old papers that I wrote in grad school, and I was just like, wow, I can't believe people actually used to write these things by hand. So.
All right, thank you, Roman. So our next question is about what excites you most about the potential of AI in healthcare, and what gives you a pause? So this is pretty much random. So if you want to discuss, share with us, please go ahead. So what do you feel most exciting about AI, or what do you feel something you don't like AI?
Yeah, so maybe I'll dive in. So I think what excites me the most is that, when I was working in this even 5 years ago, to have a concept and see it in implementation was often a 12, 24-month pipeline, and that would be before you could really have an answer whether this is going to be something useful. And we have all these issues in healthcare. In the last couple years, with a lot of this generative AI boom, the ability to go from concept to implementation is really shortened. And we're seeing products that are really changing and addressing a lot of these issues that we have. So I'll use an example. Ambient Scribe is probably the most, I guess, probably the most disruptive early technology that we're seeing. And so what is Ambient Scribe? That is, when you're having a conversation with your doctor, this AI is recording this conversation and transcribing it for the doctor, which takes a lot of the burden off the doctor of doing that paperwork. So we have a huge burnout crisis in healthcare. And we just completed an RCT at UCLA, so a randomized control trial, and we found signal that physicians using Ambient Scribe versus those that didn't, there was potentially decreased burnout. And so that's really hopeful, and that makes me excited. I think what worries me is some of the things that we're moving very fast, and so are the means moving faster than the reason why we live, right? So the Martin Luther King quote. And I do worry about that. I think, not losing sight of the purpose of this, making sure that this is equitably shared amongst, our very diverse patient population with lots of different experience. And these tools are expensive, and so where we're seeing them used are often populations that not everybody's getting access to. And so how do we think through that? And even at UCLA, because UCLA can pay for Ambient Scribes, there's a lot of hospital systems that can't. And so that worries me. And then I think the other thing is there's a lot of these tools that are being implemented in healthcare without really proper evaluation. We don't know the safety risks, amongst other things, even the effectiveness. And so that worries me too.
Thank you, Thomas. Anyone else?
Yeah.
Yes, go ahead.
Similarly to Thomas, what excites me most is like what we're here to talk about today, which is like creating access and equity and kind of evening the playing field and things that we wouldn't be able to do otherwise. I think, for example, for us, we had a product at CHLA that was able to do medical translations. So prior to then, not just CHLA, but a ton of hospitals were sending, patients home with care instructions in English. And if you only speak Spanish, that's a problem. And so just adding that layer of protection and patient safety and making literally your own healthcare information more accessible is something that I'm most excited about with the use of AI. And something that gives me pause, I would say, is maybe the lack of guardrails or people just using AI irresponsibly, because it is exciting, it's new, it's fun, it's bright and shiny. But at the same time, if you use it and you're moving so fast with it and there's no kind of thought behind it, or maybe even discovery that it takes to do your research before using it, that's where, for me, it gets concerning. So that's what I say.
Thank you. Yeah, go ahead, Nona.
So I would echo what the other two panelists have said. I am also really excited about the potential for AI to help physicians in settings where there are just not enough providers. We have basically in the U.S. Fewer providers than we need. And in many areas, in medically underserved areas, what AI can do is make the existing providers a little bit more efficient, more effective at what they're doing, so that even though they have a larger volume of patients that they're seeing, they're still able to get things done with quality and with good outcomes for their patients. The ambient scribing that was just described, I think, is going to be a game changer, because the documentation, how many of you have been to a doctor who sort of faces the computer and is typing, trying to get everything in? And what ambient scribing from just the patient perspective can do is your doctor is looking at you and talking to you, not facing the computer and talking to the computer. And that makes a huge difference in patients' perceptions of whether physicians care about them. And so I think things like that are really going to help. Where I have pause, so in addition to things that others have mentioned, is the use of AI. So right now there is a class action lawsuit moving through the system against United Health based on AI that they created to deny claims for seniors on Medicare Advantage. And if you think about the use of AI in that way, it's a use of AI in healthcare, but it's to deny care. And that is not what I'm about. I hope that is not where things go, but we have to be aware that that's one way in which it's being used. Cigna and Humana have also faced lawsuits for similar things. So while we're excited about the potential and moving forward, we should also be aware of these other use cases for AI.
Thank you very much. Which actually lead to our next question.
Go ahead. Yeah, I was going to jump in. So just on the behavioral health side, because I think this is a little bit different. We have a current mental health crisis, a current substance abuse crisis. So LA County is the largest, LA Department of Mental Health is the largest public mental health provider in the country, for example. And last time I checked, it was 1, maybe 2 sites are open on a weekend. So if you could have a psychiatric crisis between Monday through Friday, 9 to 5, there's a public mental health available for you, which sounds crazy. AI offers for the first time the ability to get help when you want on your terms. Same for substance abuse. People who want to quit don't want to wait till the next day because they know they might use again. And so that's the promise, right? The fear is the public mental health and public behavioral health workforce isn't really involved in creating most of these AI therapy models. So, there's been a bunch of stories in the New York Times lately about the famous one with the ChatGPT leading to suicide of someone seeking help. So we need to somehow leverage the AI companies to include the public behavioral health workforce, but the possibilities of finally getting care. Dr. Parham talked about the digital divide. That digital divide is also a services divide. In those communities, there's a lack of mental health care. There's a definite lack of substance abuse care. There's a lack of foster care. So there's a real divide as well, and AI offers a chance to finally address that, but it has to be done in conjunction with people, I think you had pointed out, with safety, knowing it's safe, knowing it's effective.
Thank you, Seth. So we actually just touch upon this very important topic about responsible and equitable AI, right? So really the question is that how can AI be used to reduce disparities rather than exacerbate them in LA County's healthcare systems? Or can you provide some concrete example where AI has either succeeded or struggled in serving underserved populations? So what lessons have we learned? Go ahead.
Yeah, I think there's so many things that we can do, right? And kind of the product I just spoke about for CHLA, it wasn't just a good thing to do. It was the right thing to do to build a product that serviced our primarily Spanish-speaking population. 63% of our patients primarily speak Spanish, and so it was imperative that we sent them home with instructions in their primary language. So that's for one what I would say. And then also I think when we're building these 0 to 1 products, if we're not partnering with a vendor, it's important to bring the people in that we're building these products for. A lot of things, unfortunately, across tech in general happen in a silo. And so we're like, okay, they have this problem. Let's build something for them. But did you ask them? And so that's something that I think is really, really important. And also when you're building, a particular model, diverse group of people and an array of people to be involved in the building and asking them what they think, what their experience is like, because it's never a one-size-fits-all. It might be the easiest or most efficient or the cheapest thing to do and the quickest thing to do, but it's certainly not the best way to do things. And so, yeah.
Thank you, Margaret. That's very important to hear. Yes, Nona?
So I'll say, in terms of medically underserved communities, purpose-built AI can be a good thing. So for example, if you imagine that somebody took an AI model, so how many people are familiar with Loma Linda being a blue zone? So imagine I went to their hospital, I got data on, let's say, I'm looking to build an AI model on diabetes, right? So I build my model. So this is a community where people live to 90, 100, they're mostly vegetarian and so on. And if I took that AI, tested it there, it works great, and I plunked it down in the LA County Department of Health Services, how would that work? Okay. And so this is part of the problem with using, so people talk about data bias, but sometimes it's not intentional. You start something somewhere, you're like, it'll generalize to this other setting. And so sometimes what you need is AI built for a particular community, not just, AI that you built on a majority population and that you're hoping will work for everyone. And so one of the projects that I've been able to work on with folks in the county, ophthalmologists and other folks, is not just AI, it's telehealth in combination with AI. We're looking at diabetic retinopathy, which is an issue in LA County because it's a consequence of diabetes that is the primary cause of blindness in the US. And so one of the things that the county has been able to successfully do is introduce teleretinal screening, so remote sort of screening where you have a camera take a picture of the back of your retina, and a remote physician can diagnose what's going on with you. It addresses the issue of not having enough specialists in a particular area. And then another thing we found after a pilot at Charles Drew, which led to the countywide program that's instituted right now, is that still not everybody comes in to get that picture of the back of their eye taken. And so we decided to look at whether, we knew what the risk factors for diabetic retinopathy were. We decided to look at whether, just from somebody's electronic health record, you could predict whether somebody had retinopathy or not. Just, they're sitting at home, they don't have any symptoms, they don't know, and we found that you can. It's not as good as coming in, but that allows physicians to reach out to the population that's most at risk and bring them in for whether it's treatment or whether it's more screening. So AI that's sort of purpose-built has its place, but also making sure that we are collecting data from populations that are often not whose data are often not used to build these AI models is important. And that might require more creative thinking, policies, incentives to include a broader group of people in the data that's being used to train models.
Yes, Roman, go ahead.
Sure. Yeah, maybe I'll say an anecdote. So I was speaking with our co-founder last week, who's an interventional cardiologist at Cedars, and she saw a patient who came in who was referred for severe mitral regurgitation, and she saw him, and she right away recommended him to get a mitral clip replacement. But she said that this was his fourth echo, the fourth time he had an echo exam in the last couple of years, and she said this clearly should have been seen by the first or the second echo. And what's more, even though they were going to do the surgery, she said at this point, his outcome is statistically less likely to succeed because they already waited too long. Now, this patient was referred to Cedars-Sinai from, I think it was some clinic in San Bernardino, a more rural, underserved community. So I think the opportunity here and the vision is, why can't every patient across the country, urban, rural, high income, low income, whenever they get imaging done, have an AI that can look at their tests that is perhaps the equivalent of somebody who is world-class in that field, and at least triage them and say, hey, we don't know for sure, it's never going to be as good as the actual doctor, but maybe this person should go see a specialist. Why can't we do that not just in the US, but in developing nations? I think that the less expertise there is, the more of an opportunity there is for AI to add value. So I don't know if our product is going to be such a slam dunk at Cedars-Sinai. They already have some of the best doctors in the world. But, let's say a rural area in Vietnam, and they did this study, those people might never have access to a cardiologist their whole life, let alone have an echo. So I think that there's a tremendous ability to add value.
Thank you, Roman. So actually, our panelists, they are all professional, healthcare practitioners, right, with the AI backgrounds. And so our next question is about the operational and the clinical values of AI in healthcare. So from your perspective, what are those high leverage use cases in hospitals, clinics, and community health? And by high leverage use cases, we mean as patient safety, workforce augmentation, operations, diagnostics. Anyone?
Yeah, I think I probably would have answered that question differently even a couple of years ago. I think we're seeing AI across all these different use cases, but I think the challenge is that, in clinical practice, the amount of evaluation that we need to do is pretty high. And I think that's an area where we have to be kind of really careful about implementing these tools. But there's all these things behind the scenes that happen in healthcare that are really important to the patient's journey. Mm-hmm. And I think that's an area that often gets overlooked and should be, and has been recently, I think, especially at UCLA, I can speak to, a focus on addressing, how do we get people scheduled more quickly? How do we do triaging? How do we, making the patient's, portal, answer questions or see labs and have results reported back, maybe with the interpretation of help with the interpretation of an AI tool. I think these are the kind of applications that we're gonna see really change people's experience with healthcare in the next year or two.
Thank you, Thomas. Anyone else? Yes, Seth, go ahead.
Again, a little bit different in the behavioral health side, but I think an example of outcomes, and I think this also touched on the last question. So colleagues former colleagues at USC, for example, who are looking at, if we look at a database of homeless participants, who's most likely to be successful in housing, so that we could prioritize who would go into housing. I know there's also similar studies who would respond well to psychotherapy, and we could prioritize which clients get it. I think this gets a little bit to the disparities, though. Part two, what do you do with the clients who don't do well, right? And so in some ways, we're sort of training AI. A lot of times we think of bias as a factor, that things like ethnicity, socioeconomic status, but there's also bias for outcomes, that we want success. And I think in social work, for example, we're oftentimes dealing with the clients who struggle the most. And so what worries me is if we do get these great efficient models that boost efficiency and boost outcomes, what we're left with is a pool of people who struggle even more. And I think one of those parts of where we need to be careful in the ethical decision-making around AI is accounting for what happens for the people who are not optimized, who are not efficient, because they're the ones who actually need the most help. So I think that's an indicator for clinical thought.
Thank you, Seth. So we only have like 5-10 minutes left. So for the sake of time, let's switch gear a little bit to talk about the workforce and education impact of AI in healthcare. So my next question to our distinguished panelists is that how is AI changing the skill sets required in healthcare, both clinically and non-clinically? What should college, university, and training programs in LA County, including our community colleges, be doing to prepare to this shift?
I might be slightly biased because I'm a product manager, but product management is really important. I think it's important for schools to teach their students how to be investigators, first and foremost. I just think that in the future. And even now, companies, institutions are going to be looking for like ultimate problem solvers with AI. And so not just slapping AI on top of something, a problem that they might have, but really layering it through and working with AI. And that requires asking tons of questions over and over again. And we have this thing in product management called the 5 whys, right? So you ask why literally 5 times until you get to the 5th answer. And each one of those whys will tell you something that you need to know about the solution that you're going to build. So I think it's just about schools introducing that and excuse me, AI at every level. So it's not just maybe having like a panel like this, or maybe having an AI education session for upperclassmen, but it's like literally at every level, at every role, AI has a place. So I think that's just super important.
Thank you, Margaret. I'm
Bill?
taking notes to put what you said into my teaching next time, you know. Thank you, Margaret.
I think
Thomas, go ahead.
what isn't probably surprising to many of you, our medical students are using AI way more than our kind of senior physicians in their daily life. And so they're really adept at using this technology. I think what we need to do is in UCLA and other academic medical centers in terms of medical education is work with our educators, because they are not integrating AI often into our education curriculum and into our training. And medical education historically, because medicine's a huge volume of knowledge, so when you go through medical school, a lot of the way that you're assessed is just memorizing this huge volume of knowledge, and then how well can you regurgitate it, right? And I think there's a problem with that, and I think it doesn't emphasize that critical thinking, the asking the why. Sometimes you're just memorizing this content, right? And these AI systems are really good at information retrieval. You can have all of medical knowledge on your cell phone, and it can help you access that really quickly, and very context specific now with these AI tools. And so we have to work with our educators to start thinking about how we leverage this. And I think that our young students are going to be very good at picking up on it. So, you know, my focus has been, we need to teach our educators as well.
Thank you. Go ahead.
So, I would definitely agree, but I also think that a lot of students now and educators need to be taught about prompting, and that's a very important skill to have right now. But and in another regard, with more traditional AI, so a lot of the students I'm dealing with are going on the clinical path, and being able to ask critical questions about how well models do, not just accepting, you know, the sort of hype or just being able to ask things about if you have a fit-for-purpose AI that's supposed to be dealing with a particular disease, what's the sensitivity of the AI? What's the specificity? How good is the model? And being very concrete in looking at that, in making decisions about what AI to utilize.
Thank you, Lola. Our final question, actually, for the sake of time, is, you know, to wrap up, what must Los Angeles County commit now to ensure we need AI-enabled, equitable healthcare rather than fall behind? I would like each of panelists give us like 30 seconds summary or vision about what you think about this question. Thomas, go ahead.
Yeah, I think we need to demand evaluation. I think we need to support that. I think it needs to be unbiased validation from people that don't have vested interest in these AI tools. We need to bring in our diverse expertise. These tools touch a lot of different aspects of healthcare. So, you know, we're just talking about how social workers, and they haven't been involved in this process, and mental health care workers haven't been involved in tools that are used in mental health. We need our diverse expertise at the level of building these applications, and not just technologists, and that's where I think.
I see. Thank you, Thomas. Seth, go ahead.
Yeah, I would echo that. We definitely need the public behavioral health workforce involved. I also think we need to demand clear outcomes of what we want the AI to do. So for example, back to using AI as a therapist and then leading to suicide as some of news has been covered. The AI, its goal is to have you just keep using it. It doesn't care about you ultimately. And so I think the county and the state need to, when they're partnering with AI companies, make sure there are outcomes that are focused on the well-being of the end user before anything even begins. And then that leads into Thomas's point about evaluation as well.
Thank you, sis. Margaret.
In addition to bringing in everybody as we go forward with AI, I think data hygiene is really important, right? And we have this saying, junk in, junk out. Like your model is only as good as your data is, right? And so it's really important to, I would encourage the county when they're doing studies on a large scale, and if you ever really expect to move forward with AI in a way that is equitable, highly encourage the county to get really hygienic with the data and make the data so that it's truthful and honest and representative of all of the communities in Los Angeles, not just small pockets or for a few.
Thank you. Luna?
So I love the things that the other panelists have said. So I'm going to look at a different angle, which is there is, at the national level, this All of Us project that tried to get data from a diverse group of people across the US. I think similar initiatives could be done at the county level. And sort of incentives to have, you need data, you're learning from data. If you could get quality data from a wide variety of people in LA, in the state of California, that would be great.
Emma, go ahead.
I think in the course of the AI revolution in healthcare, there's going to be a lot of mistakes made. There's going to be a lot of very expensive mistakes made. And I think one thing that a place like LA County can do is get all of the decision makers and the stakeholders and the clinicians together so that they can actually talk about what works and what doesn't, because it's much cheaper to learn from someone else's mistake than from your own.
All right, thank you so very much. With this, we conclude our panel discussion. Let's thank our great panelists one more time. Yeah, we can certainly carry this discussion into our next session, the networking in reception. So we are looking forward to all your discussion. So we do have some questions from the audience, and we have many questions, which is fantastic.
All right, so thank you very much for an amazing conversation this afternoon. I like the fact that your school was able to do a RCT on AI. I'm wondering how that was done, but maybe we'll have that conversation after. I believe that what we need, like everybody have said, is both an in-out and an out-in innovation. In-out where we know what we want, and we call a young man like Roman and say, help us, let's develop this together. And out-in where Roman says, do you have this need? I can provide it for you. Any AI tool developed right now without the user's involvement, without the faculty involvement, students' involvement, patients' involvement, is a waste of resources. And we should not do that. We have made this mistake over and over again, and we are still making the same mistake, even in this age and time. That should not happen. Number two is the fact that digital divide that we mentioned, AI cannot solve that. Somebody who does not have a GSM cannot use AI. If you don't have internet, you can't use AI. So whether we like it or not, AI will continue to advance and amplify the current digital divide that we have right now. What we need to do is, how can we solve the initial problems, the basic problems, the socioeconomic problems that people have right now? That is the only way AI can help in that dimension. Thank you.
Oh yeah, go ahead.
I don't know if I totally agree with almost everything you said. Actually, all of it. It was mostly commentary that I agree with, and I think the point is taken that we often we get so excited about AI. We're starting with the technology first, and I see this way too often. I still see this. We'll have an AI tool that's developed, and then we start to look for the problem that we're going to solve with it. And we can't do that. Yeah.
All right. Yes.
Thank you very much for being here. I have a question about workforce and the comment about the students at CDU, students everywhere, who are concerned about being able to come into the workforce, and is AI replacing, future opportunities. So for a few of you, when you have your models, do you also have a workforce development component that goes into kind of most, I won't say every, but most of your AI models? So you're also somebody else on the other side, not the inventors of the AI, but they're like, what does this mean to our future workforce in terms of taking away jobs or bringing in more jobs?
That's a tough question.
May-
Go ahead.
Yeah, maybe as the person building these models, I think that's the biggest kind of chuckle I get when people say it's gonna take away jobs, because we're just not good enough yet, and I don't think we're potentially ever going to get good enough, and I don't think that the FDA would let us do that. So, I on my end of things, I don't see that as a real issue. In fact, I would say clinicians are our biggest champion in the workforce. The other thing I'll say is that what I think will change is, if you look back, today, administrative costs account for 30% of healthcare spending, and it's the fastest growing component. If you look back 30 years ago, when we had the digital revolution, I think somebody might have thought that, we're going to lower administrative costs, and actually that's not what happened. It dramatically increased. So, my hope, I really truly hope that this time around it will be different, and that AI can help with that. I'm very bullish on that. And then what I think was going to happen, because we are spending so much on healthcare in this country, instead of taking away clinical jobs, some of that money that we save on administrative costs is going to go to hire more nurses, hire more doctors. There's huge shortages in both of those. We need more of those frontline clinicians, and I think that's my vision and most optimistic view for AI.
So I'll say what I tell my students. So there's a reason they are required to take a course that includes AI. And is that physicians who master using AI as a tool will, I think, do better than physicians who don't. So it's not a matter of replacing them, it's a matter of giving them better options to work with to be more efficient.
Thank you.
You're always gonna,
Go ahead.
You're always gonna need a human in the loop, no matter what. So that's definitely not going away. And earlier to Roman's point too, for everything that's being built with AI, you need a team of people to manage said tool, quality assurance, the whole nine. So I definitely don't think AI will just completely replace certain roles, and I also think that it still allows people to work at the top of their license, right? So we had a lot of nurses trying to do scheduling and taking care of a patient. We did have an AI tool take over their administrative tasks, so they can just be a nurse.
I'll just add, I have a slightly different take. It's sort of morbid, but if you didn't need me, if you didn't need social workers because we solved homelessness, incarceration, and mental illness, that'd be awesome. But AI, in terms of AI replacing, I do think in terms of workforce, on the behavioral health side, we're not really great at our outcomes in the behavioral, we're not hitting most of the milestones we need to. And so I think the shakeup of having a workforce that's more open to data and more open to having help identify problems even before they occur, like child welfare, right? Knowing which kids are most at risk. Those would all be amazing, and I think we're nowhere near really the workforce replacement period, but we definitely are near the point where this can be a great way to actually better drive behavioral health practice.
There was a study that was published, I think it was maybe 8 months ago, that really kind of shook the foundation of the AI informatics healthcare landscape. And essentially the study looked at people with rare disease coming in and presenting. They had 3 groups, and 2 of they weren't actually planning on having. I'll get to the study. So the 3 groups were AI alone, physician plus AI. And so it was physician plus AI, physician, and physician AI alone. And the expected result was that the physician plus AI was going to do better than the other two. And that's always been the kind of general census, and that's why we talk about human in the loop. And the physician plus the AI got the diagnoses right about 75% of the time. And the physician alone got it right about 74% of the time. There was no statistical significant difference between the two. And then the AI alone got it right 96% of the time. And so is AI going to replace jobs? Maybe. And I'm not probably the right one to make that prediction. But I think actually what I took away more from that is that we have a huge education divide, because the physician plus the AI should have been at that close to that 96% or above. And there's something about that dynamic between the physician using the AI that didn't allow the physician to perform better. And so I do think that education really needs to be a focus here, because these tools are really powerful and they can help patients. So we need to start thinking about that.
All right, we do have one more question.
Hi, yeah. It seems like a lot of the panelists are interested in the applications of AI to improve health in underserved communities. But one thing that didn't come up in the conversation is the trade-off that comes with AI usage is more data centers that are detrimental to environmental health and are often in underserved communities. So I'm wondering how your organizations are weighing this trade-off.
We talk about that a lot, actually, at CHLA in the Innovation Studio. And unfortunately, the short answer is that we don't know right now, like, what that looks like. I really don't have a direct answer for you, actually. But there are discussions about, like, where you kind of strike that balance. And it's really bad for the environment. And, but we're solving one problem, but you might be introducing or adding fuel to the fire somewhere else. And so I think it just is going to take a lot of ongoing discussion. I do think that problem will eventually be able to be solved, but I think we're kind of putting one foot in front of the other right now when it comes to AI as it relates to the environment.
Thank you.
Yes, thank you so much. All of you all had so much information to share to all of us. And so I thank you for your time and also everything that you presented. My main concern, since I do work in the unhoused community, and you did bring up a really good, interesting point that, AI could even probably sort out who would be the best candidate into housing versus those that are not. And that's very interesting, because maybe I'm just not there yet, even though I use AI personally myself. Because when we're working with individuals who do not have mental issues or substance abuse, they're just actually getting hit during this economic time of not having sufficient income, and that's why they're not being housed. Or maybe they've had trauma in their lifetime and they're having triggers, and IPS could be, one of the ways of helping them gear into getting housing. Maybe it's motivational interviewing or other type of evidence-based methodologies that can help, versus just going through a system like AI that's going to make a decision on marginalized communities. That's usually what I usually see, that's unhoused, to be able to make that decision. So could you clarify that? Because I'm not really understanding whether those biases would be there and that could be detrimental to the communities, or how could it actually work? Thank you.
So I think it's a good question, and that's why I was saying about the concern about using a model like that. But we know that there are across different fields, right? So in mental health, there are some people who respond better to psychotherapy, some to medication, right? So there are some studies looking at MRIs, and we could predict who is going to do better with each. In child welfare, there's efforts to try to predict which families are most at risk. So there's an effort to try to figure out who's likely to be stable in housing once we get them housing, because the turnover in housing. So I think it's a population, it might be a subpopulation not just unhoused population at large, but who are dealing with serious persistent mental illness, for example, or substance use. But the way it works is it's looking at predictive factors. So it's looking at the case history of the individual and then trying to make a determination of who's likely on that list to do well. I'm not advocating for it. I'm just saying this is something that exists. But your question about how would it work, you know, the truth is people end up homeless for a wide variety of reasons. It's not a monolithic population. Foster care, for example, is a huge gateway into homelessness. So I think the idea is that we could use data much better than we have. And we do a pretty poor job of preventing problems that might be more observable if AI is looking. But I do want to say about the bias, because I think this is important. We have a lot of bias. I'll give you an example, right? So I'm a social worker. I worked in many housing programs. We have a bias about who we think is good for housing, too. And a lot of times our bias is wrong. We like the clients who show up, who do, right? But that may not be the client who actually does well in housing and who responds well to treatment. So I'm not saying AI is less biased than us. I'm saying there's different biases. There's trade-offs. We need to be aware of them. We need to look at them. We need to think about them. But I would just caution to dismiss it as saying there's bias. Part of why we've done so poor is that humans have bias too in figuring out who we want to give services to. And that's because it's a scarce resource. We don't have enough social workers, mental health practitioners. We don't have enough of anything. And so we make decisions based on our own biases already.
So let's thank our panelists one more time. Thank you.
They want to stay and answer some more questions. We can make it happen. But no, please, we want you all to stick around. We're going to have some closing words now from Kendall Turner on behalf of LAEDC. But then please stick around because we're going to have refreshments and food over there on the side. And we want you all to continue to ask questions and network with our panelists. Kendall Turner.
Thank you, guys. Thank you for such a rich conversation. It was an incredible discussion. At this point, we just want to take a moment to thank our panelists, our moderator, Dr. Bintang, and our keynote speaker, Dr. Parham, Dr. P for some of you. He reminds us to look at this glass as half full. While this can be our greatest weakness, we want to see this as our greatest strength. We learned a lot today to remind us that AI is not just part of a technological evolution, but it's a societal turning point. They gave us a couple demands: demand evaluation, demand clear outcomes, demand data hygiene, demand diversification, and demand convening for solutions and lessons learned like we did today. But they also cautioned us that the digital divide can become even bigger. So it's pushing us to rethink how we educate, how we deliver care, and how we center justice in systems that haven't always been equitable. Because the truth is equity, innovation, and economic development are not separate goals. They're deeply interconnected. And I think about what one of the panelists said about servicing patients through language in a county where 224 languages are spoken. That could be pivotal for many of our people in our community. In the future of healthcare in Los Angeles County just can't be about treating illnesses, but it has to be about healing systems. At LADC, we are deeply committed to continuing work not in just words, but in action. The insights from today's forum will directly inform how our regional healthcare workforce strategy, a new curriculum alignment process for our education partners, policy recommendations that advance inclusive tech adoption, and cross-sector convenings like the ones they spoke of today that will ensure no community is left behind. We'll keep integrating these principles into our talent pipeline management work, our California Job First strategies, and our sector-based equity initiatives, because the future of healthcare in LA is a future we must all help shape together. So thank you again, Cal State Dominguez Hills, to all of our partners and to each of you for leaning in this conversation for purpose, urgency, and heart. Let's leave here not just informed, but ready to lead. The conversation doesn't end here. It continues in our classrooms, our hospitals, our boardrooms, and in every community that depends on us to get it right. So as we head into the networking reception, let's keep connecting, keep collaborating, and keep imagining what's possible, because the future of healthcare won't be written by algorithms. It will be shaped by the people in this room. So thank you, and it starts here today. Let us join in some food and festivities.